Hi, everyone. My name is Patty Stott. I am outside of the Colorado area in the United States, and I primarily work with patients with symptomatic hypermobility in the functional medicine and rehabilitative or movement space. Today, I want to talk about considering some modalities that we might use when the patient is more sensitive or more reactive, and we might get a different response. So we're going to talk about some of those modalities, but really the concepts behind them so that we might be able to make some modifications that could benefit rather than flare up the individual. A modality is a type of therapeutic agent that we use that can assist with the treatment of an individual. So these are things that should make you feel better. They should be adjunct treatment, something that's nice to apply to the patient. We have so many different types of modalities that are out there. This is not an exhaustive list. There are things that I'm sure I don't know about, but the good thing is that we have so many options, different things to be trained in or refer the patient out for. But we're going to talk about some of these selectively and the concepts so that we might be able to apply them across the board to some of these other interventions. It's important to understand the layers of the person that is presenting that we're going to give this modality to. There are layers with these patients. We have this trifecta of symptomatic hypermobility, MCAS, and POTS. So we have issues with the connective tissue, the immune system, and inflammatory response in the nervous system itself. Each one of those are complex. So we have MCAS, or abnormal mast cell activity, that can really get into this vicious cycle with dysautonomia. Can be correlated with patients' illnesses as well, chronic infections, chronic GI issues, toxin or environmental exposure. So in and of itself, mast cell responses can be very complicated. There's the complexity of the autonomic nervous system. It communicates and it helps regulate heart rate response, GI motility, blood pressure, sweating response, temperature regulation. It also has associations and correlations with some psychological diagnoses, ADHD, anxiety, and autism. So again, a very complicated system in and of itself and how it responds when it's dysregulated. Not only that, but we have other coexisting conditions in this population as well. We could be seeing upper cervical instability, tethered cord syndrome, Tarlov cyst syndrome, median arcuate ligament syndrome, or compression of that celiac plexus, spinal or cranial CSF leaks, and all of that can feed into how those other issues with the trifecta are communicating with each other as well, because it can produce dysregulation. So they can all influence each other, and they can all influence the way that somebody that has these conditions are going to respond to an intervention. There's other things as well outside of this trifecta, but the trifecta is part of it. We can see these other things that are going to influence how a patient might respond to input that we give the body. Abnormal mast cell reactions, again, illnesses, stress can change the way that we respond to something, sleep hygiene, dietary choices, is it pro or anti-inflammatory that they're putting into their system? Environmental factors as well can really influence not only the mast cell response, but the autonomic nervous system. Chronic fatigue, that in itself is a layered presentation. So again, we might not see the same response that we would be expecting. We can see anatomical issues with the nervous system in a diseased phylum or tethered cord, upper cervical instability, and then this functional component of the nervous system with dysautonomia or POTS. So again, there's so many things that can influence how somebody might respond to something that their body is trying to translate. So what are the problems that we have when considering modalities, especially in this population? Well, some modalities are actually intentionally meant to cause an inflammatory response because we're looking for that domino effect. We want to actually induce inflammation, get all of those good cells in so that we promote the healing response that we see. And this takes a coordination of mast cells and mediators. Some other modalities, because we have this communication with the nervous system, it's interpreting what's safe and what's not, can actually trigger dysautonomia reactions if that autonomic nervous system is dysregulated or it's not properly responding to input, like we see in dysautonomia. So what's the solution? It's really down to understanding the patient in the moment and more globally, how their system has been responding and what it's doing that day. Very specifically, whether it's systemic or local where we're applying the modality itself, what is the response of the immune and the nervous system? So we really have to pay attention to those two systems to be able to get a normalized response that we would be expecting. So again, inflammatory and nervous system response, super important. Again, we want typically this inflammatory response to happen with some of these modalities, especially manual strategies that we might have. This stimulates the process that's going to lead to rebuilding the tissue. But if you have an abnormal mast cell response, you're going to have potentially an abnormal inflammatory response locally or systemically to that intervention or modality. With the nervous system response, that really, again, controls the communication. Is this a threat or is this beneficial to the body? And while I'd like to say that we have control over how our body responds to things, this really comes down to a cellular nature, or the nervous system, really how it's wired, how's the electricity flowing through things. So we don't necessarily have as much control, especially in the moment, if the individual is in a flare-up. With the nervous system response, it's going to determine how the nervous system is integrating information that's put into it that day. In other words, is it in homeostasis? Is it balanced? Can it sense something safe from something that's a threat and tell us appropriately? Or is the patient more in that fight or flight type of response, that sympathetic state, where if you introduce something, it might register mostly everything as a threat? It's going to do that with modalities as well, potentially. And then we can have a freeze response. So the body shuts down in protective mode because, again, it's sensing a threat to the body rather than something that should be beneficial. We're going to review some of these modalities and really the concepts behind them so that hopefully we can apply them to different types of modalities, because there's so many out there. Education, I include this because we have to have education with our patients. We really have to consider this a primary intervention with everybody that we work with. It's a modality in itself. The more the individual understands about what's going on, the more that they're going to be able to use those tools themselves appropriately in the moment, but also in the future as well. So it's tools. They'll be able to figure out what works for them and in what scenarios. We know that behavioral and educational interventions combined with proprioceptive exercises is more beneficial, and it improves the patient more so than just the exercises alone when we're dealing with chronic pain. So we have to have this educational component, absolutely. And this education piece, we can talk about these abnormal responses so a patient might be able to have better communication as to what they feel their body is going to respond better to in the moment. Soft tissue mobilization, again, wide berth, plethora of different types of modalities that are out there, not an exhaustive list, but this is a good thing because we want different types of soft tissue work so that we might be able to pick something more appropriate during the day. There are differences in how this is applied overall. So again, different ways that we can modify how we're interacting with the individual to make it more beneficial rather than potentially a flare-up. So how it's applied, it can be hands-on, whether it's the therapists themselves or self-applied as well. By the patient or individual. We can use instruments, so some plastic or metals that they use that might actually help, whether it's scraping or trigger point release, the speed in which it's applied as well. Are we using a still pressure or are we using rapid strokes, which might be more stimulating to the nervous system? The amount of force used. It can vary from hands-off, that energy biofield approach, to more of a deep pressure modality. So again, a lot of different options out there to consider. We can adjust so that we're, again, benefiting rather than causing more of an inflammatory response. So when we're dealing with more this deeper pressure, we have to remember about this neural inflammatory piece as well. So not even just the communication that we're having in this autonomic nervous system response, but just locally, if we're having neural inflammation, neural sensitivity, neural tension that's happening, we need to be really cautious about putting that direct, deep manual pressure in around those more superficial nerves that might be irritated. So we really want to make sure that we're not causing more inflammation around those nerves. And again, the nervous system, that is what's responsible for interpreting whether something is safe or a threat. So a person that has altered perception, altered translation, they're not getting the right signals and their body isn't giving them the right messages, might interpret those deeper techniques as more of a threat. And it might trigger a protective response from the autonomic nervous system. We do know that when you put somebody on a foam roller, the outcomes, whether they feel better or not, is based on the state of their nervous system. So again, those trigger points are going to respond globally to how the nervous system is related. If your nervous system is regulated and you're in a more homeostasis state beforehand, you're going to have good effects from the foam roller. If you are dysregulated and you go onto a foam roller, it's probably not going to feel better and it could feel worse. We do have different types of considerations for people that do have more of an over-responsive system, especially when we're in those sympathetic states as well. We can consider the lighter touch when we're doing soft tissue work. So Swedish, effleurage, myofascial release, trigger point release. When we're talking about trigger point release, it's most effective actually with more manual gentle pressure, and this is typically about 1 kilogram or the weight of a pineapple. There's also positional release strategies or fascial counterstrain methods as well, and lymphatic work. So stereotypically, these do work a little bit better when we're seeing abnormal sympathetic responses from the individual. And I know that there are a lot of people out there that have that spot that they feel like really needs to be released. But we have to remember that there is a more global effect. And if we're talking about using some of these strategies, it can actually work locally as well. So we have these interventions that just generally decrease overall sympathetic activity in the whole body. When we decrease that sympathetic activity, we can also decrease that fight or flight response, and that input to those big power moving muscles. Those are usually the ones that are causing the muscle dysfunction. So again, we can have a global effect, but it comes down locally, potentially to the area that is feeling it. And that can actually lead to improved localized tissue dysfunction. So we're having a global effect, but it can actually affect that small area that we really want to dig out. So lighter modality strategies can be a less is more type of effect for these patients. Well, when do we use trigger point versus those positional releases? So a trigger point release is typically when we have something that's deep and achy and it radiates in a familiar distribution pattern to that trigger point. You know, you see those charts and that's the trigger point. That's exactly where I'm having my pain. Those are going to respond better to those deeper pressures, but it's a weight of a pineapple. So that longer hold on that trigger point could help release the trigger point in that fascial or muscular area. Positional releases is more indirect. So this is typically where we position that muscle or fascia into the greatest slack in that direction. And there's a stretch in another plane as well, but we're focused on where that tender point is. And positional releases are really good for those hypersensitized areas that feel super sharp, like a bruise. So it's just more reactive than our standard trigger point. And this is usually hold in that position for about 90 seconds. And actually, sometimes this can help normalize joint position as well. I wanted to talk about dry needling because this is a big topic. There's some people who love it, and there's some people who say, don't do it. So I want to talk about a few things, even outside of reactivity and responsiveness. We do know dry needling causes a localized inflammatory response. So we just want to be careful in patients that have a local or systemic, abnormal systemic inflammatory reaction that's going on. So if they have uncontrolled mast cell reactions, pause. But there are some people that do very well with this as well. The effectiveness seems to be in the trigger point release itself. So it can be very beneficial, especially if we're dealing with those tight muscles. But at the same time, if we're releasing muscles around an unstable joint, it's got to be followed up with neuromuscular proprioceptive or stability work. We know that this modality works best in tandem with others, not on its own. So we have to remember that, especially if we're talking about releasing those big power muscles that are holding on. They're doing it for a reason. They're doing it because they're really trying to help stabilize. So if we take that away and we don't help activate the muscles that are supposed to be working, over time, it's not going to be effective for the patient. So dry needling has to come with a very intentional plan of why it's being used and how it's being integrated into the rest of the session. But again, it does cause a local inflammatory response, so we have to take that into consideration in somebody that does have more uncontrolled mast cell responses. I wanted to talk a little bit about aquatic therapy. This is another one that I know there's do it, don't do it recommendations out there, and it's really patient dependent. This is something that I find is much more layered than just are they going to like it or not like it? This has to do with a lot of different systems in the body. So the connective tissue piece that I wanted to talk about is we do have some patients that do amazing with the buoyancy, and the water actually helps move everything. But then when we start moving, we have some patients that are irritated by the drag and the resistance. So this is patient dependent. Aquatic therapy might be amazing for some people and not the appropriate intervention for some others. When we're talking about the responsiveness or the reactivity, we have to consider the chemicals in the water, because those can be actually triggering to somebody that has uncontrolled mast cell reactions and also are dealing with possibly some personal sensitivities to some of those chemicals. So, we can think about window ventilation. Are we getting enough air in and out? Is there good airflow? That could be helpful. And then time limitations, especially. We want to make sure that maybe we limit it to 30 minutes, and we can have a discussion with the patient about that. I also have had some providers that prescribe their patients something to take their mast cell medications a certain time before they get into the pool. A little additional treatment strategy for them as well for the day on those therapy days. So that could be something that could be helpful for those patients. And then when we're talking about the nervous system, this can actually be affected as well, because we're talking about therapeutic warmth in the pool. We want to look for those appropriately tolerated temperatures. And again, this is patient dependent. I've had some people that need the really hot pools and some people that need the cooler pools. So it's a conversation to have with the patient and a little bit of trial and error. We can consider those time limitations again. If we know that they're only going to tolerate, 30 minutes in the warm pool, or it's only 20 minutes in the colder temperatures, we have to make sure that we're accommodating, and we might be able to increase that over time, but that also might be the limit. We have to reduce temperature fluctuations. That's really where it's this communication piece and this regulation piece that the nervous system has an issue with. So if we're coming out and having a conversation on the pool deck, it might be too long of going from warm to cold for that individual. So we have to watch those temperature fluctuations and make sure that we're limiting our time between the time on the pool deck, when transitioning in and out of the shower. We want to try to keep them the same temperature throughout if possible. When talking about taping, I bring this up for the mast cell component or the that inflammatory piece that can happen, skin reactivity. Don't see too much of the autonomic nervous system, but I know that there are some people that just love taping out there, and there are some people that react to it, and some people that react to it and still use it because it does work well for some people. So this could cause a local or systemic mast cell reaction depending on the individual and their sensitivity to adhesives. I do have patients that pre-treat with topical agents that can reduce the histamine reactions on the skin. So this is something to talk about with the medical professional. Is there something that we could put on there an hour before we're about to tape? And then we just have to monitor for skin reactions too. Also, with more hyperextensible skin or more fragile skin, we want to make sure that we're not tearing the skin when we're removing the tape as well. And from my patients, a recommendation was some have had success in applying heat before they remove that tape to protect the skin. So that might work for some people as well. There are so many different types of specialty trainings out there, and we talk about trying to figure out these more gentle type of manual therapies or modalities, and especially when it comes to working with our patients. Again, this is not an exhaustive list. This is what I've heard of from whether it's myself, my patients, or the colleagues that I work with, but positional release therapies, fascial counterstrain, visceral manipulation and neural manipulation, cranial sacral therapy, postural restoration, and Feldenkrais. We're looking for trainings or modalities that are meant to maybe regulate the inflammatory response rather than inducing an inflammatory response in the patient's body. And one of the things that I did just for fun is I went to the North American Allied Health Professionals group that we have, and I said, hey guys, what do you have when you have a patient that might be overreactive, they're more sensitive to things, and we're not getting the response that we thought that we would out of an intervention or a therapy? What do you do? What do you switch to in that treatment session? Because that is what we need to do, is we need to kind of reroute a little bit and figure out what's going to benefit now rather than flare them up. And this is just from a handful of our therapists that are out there. So this is, again, not exhaustive list. It never is. There are so many different things that could be used, but just in the few people that responded, they came up with all of this. So we have so many different types of strategies out there. We need to start making sure that we actually use or branch out into some of these techniques, think a little bit differently. What other tools do we have in our toolbox when the individual is more sensitive and reactive? So summary is always do no harm. We want to make sure that we're really precise in our treatment. What are we trying to do? What are we trying to get at? We're trying to regulate inflammation, maybe not exacerbate it. Less is sometimes more. We want to evaluate the state of the inflammatory and nervous system responses first so that we can determine what they're going to tolerate and also benefit from rather than react to. The best in the moment treatment option could be very different than what we think we need it is. And that goes for the patient, the client, and also the provider as well. We might have an idea that, again, we really want to dig this out, but that might not be the most appropriate thing and the most beneficial to help reset the system for the individual. So we have to pause and really make sure that we're assessing and assimilating how the individual is presenting and how they're presenting, what would be the most benefit. So thank you so much for listening. I'm so glad that you all are here. I always get so excited to see that so many people are interested in learning more about this, both from patient and provider side. So thank you so much and enjoy the rest of the conference.